conflict of interest briefly, and they are brief. Okay, multimorbidity and atopic disease. So this is a definition of what multimorbidity means. Multimorbidity is the presence of one or more additional disorders or diseases co-occurring with a primary disease or disorder, or the effect of such additional disorders or diseases. So in allergic disease, it's been decided that we should prefer the term multimorbidity over comorbidity. That said, when I was thinking about doing this talk, I had a look on PubMed for multimorbidities and allergic rhinitis, and I didn't find very much. Whereas if I looked up comorbidities and allergic rhinitis, I found an awful lot more. So we need to transition to using these new terms. Okay. When thinking about multimorbidity and allergic rhinitis, I think you can think about it in two ways. You can think about the multimorbidity you see in atopic disease, and this is presumably due to propensity to Th2 inflammation, so the atopy of the individual. There'll be other genetic inputs and probably other environmental inputs as well. But principally, particularly in the literature, the things that come up if you think about atopic multimorbidity are asthma, atopic dermatitis, and allergic rhinitis. To a lesser extent, there's far less out there on associated food allergy, anaphylaxis, or more rare conditions such as eosinophilic esophagitis. Now, when thinking about allergic rhinitis, you also need to think about what the local multimorbidities are. And these obviously would be things like conjunctivitis, sinusitis, middle ear problems, cough, and sleep impairment. But I think that's slightly an artificial disconnect. I think there is considerable overlap between looking at it in these two ways. All right, so let's look at the first part. So this is multimorbidity in allergic disease. What about the epidemiology? So as I've said, most epidemiological studies will look at two or more of rhinitis, asthma, and eczema, and a lot of the data will come from birth cohorts. So this is from the MASS study, the multi-center allergy study, a study from Germany. This looked at 1,300 newborns in 1990, and these were risk-enriched for allergic disease. And what that means is they had at least one parent with an atopic disease. So an impressive 942 of these individuals were followed up until they were age 20. And the rates of multi-allergic morbidity, so that is 2 out of 3 of asthma, allergic rhinitis, and atopic dermatitis, is 11.6% in males and 12.7% in females. So in 20-year-olds in Western Europe, over 10% of people have at least 2 of these allergic diseases. So at least 10% of young adults have allergic multimorbidity. And obviously this is increased in those with an atopic parent. Another study was the Swedish BAMSA cohort, so that's 2,600 children, and that looked at the prevalence of atopic disease by parental report. But additionally, in this study, blood was taken for specific IgE for a limited panel at ages 4, 8, and 16. And in this study, 51% had at least one atopic sensitization at one time point. So at one stage at the age of 4, 8, or 16, at least half of patients showed some degree of atopy. And if you look at what sensitization is associated with, it's associated with the combination of asthma and rhinitis between 4 and 16 years of age. It's associated with a multimorbidity of all 3 conditions, eczema, rhinitis, and asthma, and it's associated with persistent eczema throughout childhood. But notably, and this is something that's been touched on previously by Philippe, 23% of those who had a sensitization at some stage never had any atopic disease. So just bear in mind the difference between allergy and sensitization. And this is just an illustration of that. And I think what's really notable here is if you look at the patients who've been sensitized on the left side of the screen, you'll see at 1 year of age, the predominant allergic disease is eczema. And you can see that only a very small numbers of children have allergic rhinitis and allergic asthma. We don't tend to make those diagnoses at such a young age. But by the time they get to 16, and the study obviously looked at the ages in between, by the time you've reached 16, the predominant condition there is allergic rhinitis. And you can see what the overlap is for both asthma and eczema. And that really fits with some of the data we've already seen. If you looked at the patients who've never been sensitized, you can see they will have rhinitis, asthma, and eczema, but to a much lower extent. And where does this multimorbidity come from? Well, there's considerable shared genetic origin. So in a very big genome-wide association study of what was deemed an allergic disease phenotype, that's any one or more of asthma, allergic rhinitis, or atopic dermatitis, this genome-wide association study involved over 350,000 individuals throughout Europe. There were 180,000 cases, 180,000 controls, and they screened for over 8 million genetic variants. What they found was 136 independent risk variants corresponding to 132 nearby genes, and notably 130 of 136 variants were shared risk factors for each one of these 3 atopic diseases. So there's a huge underlying genetic propensity to these common allergic disorders. But what's been shown in other studies is that you can't simply attribute this to the presence of IgE or genes involved in IgE. This is a study published a few years ago in The Lancet, and this is from the Medal cohort. So this is a combination of 12 European birth cohort studies, questionnaires sent, and also serum IgE tests to 6 allergens at age 4 and 8 years, and looking at the coexistence of eczema, rhinitis, and asthma to see if it occurs more commonly than would be expected by chance alone, given that these conditions are all fairly common in the population. So you'd expect some of them to coincide in individuals simply by virtue of them being common conditions. And then looking at this both in the presence and absence of IgE sensitization. And this study concluded that just 38% of comorbidity could be accounted for by IgE. So there are other shared factors and other shared genetic or environmental factors that are important. Okay, so moving tack a little bit, let's look at allergic rhinitis and asthma. And we've already seen some data on this. And actually, this is almost an identical slide that we saw earlier on, and this slide I've used, I think I probably borrowed it from Dr. Scadding Senior some years ago, and I've been relying on showing this to everyone, and it's a few years old now, but you can see that many patients have rhinitis, a subgroup of those have rhinitis and asthma, and actually very few individuals just have asthma with no rhinitis or no other upper airway disease. But this data is quite old now, so what about more recent studies? So again, going back to the MASS study, this same cohort, they looked at lung function and bronchial challenge tests at the ages of 7, 13, and 20. And they looked at patients with asthma only, rhinitis only, or both, so what they labeled as multimorbidity. And what's notable is that multimorbidity at the age of 7 was 3.5%, but at the age of 20 was up to over 7%. And asthma only, just 2.8% age 7, but actually less age 20. So just 1.3% of this cohort had just asthma. But if you look at rhinitis only, that increases steadily. 14% age 7, 41% age 20. And so what the summary from this, and you'll see this over the page, is that by 20, asthma is almost exclusively seen coexistent with rhinitis. And actually, if you looked at the pictures from this study from 2018, it's remarkably similar to the slide I've just shown you that we've been using for years. And you can see that the proportions are almost identical. So I think this is a real illustration of what is happening out there. What I'd say that was also notable from this study is that when they looked at bronchial hyperresponsiveness, the patients with the greatest degree of bronchial hyperresponsiveness were the patients who had both asthma and rhinitis. And that coincides with what John was saying earlier on. So those patients with multimorbidity tend to have more severe disease. What about predictors of asthma in the next generation? So there are a lot of studies looking at what predicts asthma, what predicts atopic disease. And this study looked at a mix of socioeconomic factors and also family history. And the thing I'm going to highlight for you is there in red that parental allergic rhinitis was the #1 factor for predicting allergic rhinitis in the offspring. So of all factors of income, food sensitivity, eczema, it was parental rhinitis that was the biggest predictor of allergic rhinitis in the offspring. And notably, the hazard ratio for parental rhinitis was greater than the hazard ratio for maternal smoking during pregnancy. We've seen this slide already. This is an example that allergic rhinitis, or indeed rhinitis of any sort in adulthood, is still a predictor of new onset asthma. The studies I've shown you so far tend to have been begun in young childhood, followed through to young adulthood. Well, this study shows that even beginning at the age 20, if you have allergic rhinitis, you're still at higher risk of going on to develop asthma than someone without rhinitis, or indeed someone with non-allergic rhinitis. And more of a case study, this is a paper looking at people who work with laboratory animals. And you can see that of people who work with laboratory animals, those who have no allergic rhinitis, no rhinitis on exposure to the animals, have a very low chance of going on to develop asthma. But those individuals who at baseline have rhinitis symptoms when they're exposed to the animals they work with have a much higher, almost 7.5 times higher risk of going on to develop asthma. An occupational rhinitis like this is like a little experiment in itself, and it just shows those patients with rhinitis are the ones who will develop asthma. And why is this relevant? Why do we even care? So rhinitis does impact on asthma control, and there are a number of studies out there to show that individuals who have rhinitis and asthma see their physician more. They're at higher risk of asthma attacks, including asthma hospitalization. They tend to use more asthma medication, and in particular, they tend to use more short-acting beta agonists for their asthma. And anyone who works with asthmatic patients knows that greater use of short-acting beta agonists is always a bad sign. They tend to have more bursts of oral corticosteroids, and they tend to have higher asthma control questionnaire scores. Higher scores at the ACQ indicate poorer asthma control. And if you treat the rhinitis in those with coexistent asthma, do you do them any good? And there are a number of studies. I still think we need more, and I think we need more prospective studies to demonstrate this really conclusively. But the studies out there are valuable. This was a study done by John Corrin, and this was a prospective study, and it looked at the risk of asthma-related attendance at A&E and hospitalization, and looked at whether patients were taking intranasal steroids or a combination of intranasal steroid and antihistamine. And actually, doing both of those things, or doing either of those things, reduced the risk of both A&E attendance and hospitalization. And notably, this was adjusted for asthma medication use. It's not simply that those who take a nasal spray are also better at taking their asthma inhalers, which is the first thing I would assume from looking at this data. There have been some other retrospective studies which show some fairly similar results. All right, so now we're moving tack away from general atopy and going on to those local comorbidities I described. And I should say I'm an allergist, I'm not an ENT surgeon, so this area I would be interested to debate some of these points with you, perhaps at lunchtime. Okay, so these are the local areas that I think may be relevant, and you see here we've got allergic rhinitis highlighted. So what about conjunctivitis? I'm going to mention this very briefly. Ocular symptoms occur in about 50 to 70% of patients with rhinitis. They're more common in those with seasonal disease and with outdoor allergens, and this, again, follows on from what Philippe was saying, that they tend to be more prevalent in the sneezers and the runners than the blockers. And my feeling is this a distinct multimorbidity, or is this really part of the same condition? And it's a little bit unclear to me. What I would say is that patients with more severe forms of atopic eye disease, and that includes vernal keratoconjunctivitis and atopic keratoconjunctivitis, they tend to fall into a rather different category. So patients with these conditions who really need to see ophthalmologists, they don't need to see allergists or ENT surgeons, they need to see ophthalmologists. And actually, those conditions are much more closely linked to eczema, and often to severe facial eczema, than they are to allergic rhinitis. So there's a bit of a difference there. Okay, what about allergic rhinitis and sinus disease? So atopic disease increases the risk of upper respiratory tract infections and also lower respiratory tract infections. So this is a study done in Finland, a cross-sectional study of over 1,000 allergic and non-allergic patients in middle age. So information on questionnaire and respiratory infections was gathered, information on atopic diseases and respiratory infections was gathered by questionnaire, and they also had specific IgE antibodies to common aeroallergens. So adults with atopic disease, and this is any form of atopic disease, had increased risk of having upper respiratory tract infections, including a common cold or sinusitis, also tonsillitis and otitis media, with an adjusted relative risk of 1.55. But actually, they had an even greater risk of having lower respiratory tract infections. So the relative risk for that was over 2. My concern in these cases is, what's the difference between a lower respiratory tract infection and an asthma exacerbation? And I think in a study like this, it's very difficult to tell. What's notable also is the risk increased in these individuals as IgE sensitization level increased. So if you looked at their specific IgEs, if they had a dust mite IgE of grade 1, their risk of having upper respiratory tract or lower respiratory tract infection was very marginally raised, whereas if they had a grade 4 RAST to house dust mite, the risk was considerably more raised. What's notable is that if they just narrowed it down to allergic rhinitis, they couldn't find a significant effect. But that may simply be due to the lower numbers of participants. But a couple of points from this slide. So at the top there, you'll see atopic disease with positive allergy tests, the relative risk of lower respiratory tract infection, 2.5, upper respiratory tract infection, 1.7. For rhinitis, increased, but not statistically significant. So what about allergic rhinitis and chronic rhinosinusitis? Okay. So in a large questionnaire survey of over 52,000 adults investigating the association of chronic rhinosinusitis with asthma, patients were also asked about hay fever or nasal allergies. So this is an indirect comparison. But notably, 56.7% with chronic rhinosinusitis also reported symptoms that were judged to be consistent with allergic rhinitis. So perhaps this is parallel evidence for an association between allergic rhinitis and chronic rhinosinusitis. That said, if you look back at the EPOS guidelines, you'll see quite clearly stated that the proportion of people with allergic rhinitis who have nasal polyps is similar to the general population. So there's not a clear link with atopy there. So I think overall the association is somewhat unclear. I don't think there's any really firm evidence to conclude that allergic rhinitis is a risk factor for chronic rhinosinusitis. I think that whilst IgE is highly relevant to the pathology of chronic rhinosinusitis with nasal polyps, and hence the efficacy of omalizumab in treating nasal polyps, this is distinct from atopy. So these patients seem to have a local IgE production, but do not necessarily have higher rates of atopy judged by serum IgE tests or skin prick tests. The possible exception to this, obviously, is allergic fungal rhinosinusitis, where sensitization to a fungus is a prerequisite, but I think that's a very small point. And over the page, there's a nice study that's referenced here that looked at various studies in favor and against allergic rhinitis and allergy being a predisposing factor for chronic rhinosinusitis. And what I'll highlight here is, first, in the studies in favor, some studies suggest there's an increased incidence of allergy in nasal polyps. Against this, other studies say there's no increased percentage of allergy in nasal polyps. And also what you'll note is that reference 59 is common to both those arguments, which is a little unusual. Anyway. And again, CT changes seen in patients with ragweed allergy, but no increase in chronic rhinosinusitis seen during the pollen season. And further down here, increased incidence of atopic predisposition in pediatric patients with sinusitis, but the same prevalence of chronic rhinosinusitis in atopic and non-atopic children. So I think it's not clear to me that there is a definitive link. Moving on from that, adenoidal hypertrophy and otitis media. So allergic rhinitis or atopy is certainly considered to be a risk factor for otitis media with effusion. And I think few people would disagree with that. But what about the data? So this study from 2012 looked at 291 children aged 5. This is from the COPSAC study in Denmark. Otitis media with effusion diagnosed based on tympanometric studies and objective doctor evaluation. They also diagnosed whether asthma, eczema, allergic or non-allergic rhinitis were present, and with algorithms and by taking immunocap for common sensitizations. Now, otitis media with effusion was diagnosed in 39% of the cohorts. That's 40% of 5-year-old children, a large number, and it was significantly associated with allergic rhinitis. So if a patient had allergic rhinitis, the odds ratio of them having otitis media with effusion was nearly 3.5 times. Notably, it was not associated with non-allergic rhinitis or with asthma or with eczema, so specific to allergic rhinitis. But notably in this cohort, just 10% had allergic rhinitis, so not a particularly high number. Okay. There's been a meta-analysis of studies looking at risk factors for chronic otitis media and recurrent otitis media, and the presence of allergy or atopy increased the risk of both of these by a modest amount, the relative risk of 1.3. And there were a number of other significant risk factors as well, which probably won't come as very much of a surprise. Upper respiratory tract infection, again, on studies, I think it's quite hard to differentiate sometimes an upper respiratory tract infection from allergic rhinitis in some individuals. What about allergic rhinitis and adenoid or adenotonsillar hypertrophy? So this study from some years ago now looked at 436 children with allergic rhinitis and or asthma and or atopic dermatitis. So those allergic atopic individuals we described previously. And then these were individuals who also had house dust mite sensitization. So they've got an atopic disease and they're dust mite sensitized. And they compared those with 229 non-atopic controls. And they looked at the incidence of adenoid hypertrophy. They looked at the association with the different allergic disease types and then other factors, age, sex, infection, and so on. And specifically, their stated aim was to estimate the incidence of adenoid hypertrophy in children hypersensitive to dust mites. So they found that adenoid hypertrophy was present in 40% of the atopic sensitized study group versus 22% of the control. And that adenoid hypertrophy was more closely related to allergic rhinitis than asthma or atopic dermatitis or a combination of both. But there are some limitations with this study. It's a little unclear how the children were recruited. There's no detailed demographics of the patients, and there's referral to a graph that illustrates the data that is not there in the paper. There's another study which shows an even more profound relationship that I dug up as well. Now, this is a study done, I think it was done in the Middle East, looked at 117 children aged between 1 and 14 with adenotonsillar hypertrophy and a control group of 100 children with various other diagnoses. Again, they don't tell you what those other diagnoses are. And they found that 70% of the children with adenotonsillar hypertrophy were atopic versus 10% of the control group, which is dramatic. That's very dramatic. So this would suggest that adenotonsillar hypertrophy is linked to atopy, but not specifically linked to allergic rhinitis. But again, look up the study. There's a huge lack of detail about how the patients were recruited, what diseases, the other problems the controls had. So it's suggested, but the quality of the evidence is not good. Finally, a study comparing children with allergic rhinitis and adenoid hypertrophy versus those with just allergic rhinitis. So children who have both allergic rhinitis and large adenoids versus children who just have allergic rhinitis. And the factor that could discriminate between them in this study was mold sensitization. There's been a Cochrane systematic review of intranasal steroids in adenoid hypertrophy, and it concludes that intranasal steroids may significantly improve nasal obstruction symptoms in children with moderate to severe adenoidal hypertrophy, and this improvement may be associated with a reduction in adenoid size. So a mild positive. Okay, what about allergic rhinitis and sleep? Now, I don't think many people would disagree that allergic rhinitis tends to have an impact on sleep. So this study in France, they looked at the individuals presenting complaints when they presented with allergic rhinitis. And you'll see that in adults, sleep disorders were the major concern of these patients. The major irritating factor was sleep. And in children, it comes third on the list. Presumably that's reported by their parents. So having trouble sleeping is a big problem. So allergic rhinitis has significant effect on sleep, and there's plenty of data to show that treating allergic rhinitis can improve subjective sleep quality. So if you treat your allergic rhinitis with intranasal steroids, they often sleep better, which is great. But what about frank obstructive sleep apnea? Do these patients get obstructive sleep apnea? And if you treat them for their rhinitis, do you have any positive effect on their sleep apnea? Now, the problem in sleep apnea, as you will know, is the collapsible pharyngeal segment of the airway rather than the nose. But the theory has it that if you increase nasal resistance, you then increase the risk of subsequent collapse in the pharyngeal segment. But when you look at studies of treatment of rhinitis and whether this impacts on actual sleep apnea, the data is pretty weak, in adults especially. So you can show that treating people leads to a subjective improvement, but doesn't make any difference to the apnea-hypnea index in adults. In children, there is better evidence that treatment with intranasal steroids can improve the apnea-hypnea index. But actually, most of those studies with children don't actually look at whether the children are atopic or even whether they have rhinitis. They just look in general. And the guidelines for OSA in adults and children tend to refer to intranasal steroids as an adjunctive treatment. They still think continuous positive airway pressure is the treatment of choice. Okay, pollen food syndrome, we're nearly there. So Philippe, this follows on from what you said. So food allergy is almost exclusively IgE mediated, apart from a number of gastrointestinal problems which are presumably T-cell or mixed mediated, and most of those are present in children. So primary food allergy, so primary sensitization to the allergen as opposed to cross-reactivity, is much more common in people who are allergic, people who are atopic. That said, food allergy, I think, is probably more closely related to the presence of eczema than allergic rhinitis, aside from pollen food syndrome. So pollen food syndrome, as Philippe said, particularly common. It's particularly common in Northern Europe with birch pollen allergy, but it will also exist with grass pollen allergy and with mugwort pollen sensitization. And I think, in contrast to what Philippe said, I think Snow White doesn't have oral allergy syndrome. I think it's much more likely that Snow White has an LTP allergy and that she's sensitized to MAL-D3, because that would make much more sense for the severity of her reaction. But I appreciate your point. Okay, so generally, my point there is that generally, almost exclusively, patients with pollen food syndrome have local symptoms. The more severe cases I've seen on very rare occasions, for example, consumption of large amounts of soy milk. So soy milk, as opposed to cooked soy, will have the cross-reactive allergens in it in their native form, and you can get some more severe reactions. And sometimes patients who are doing exercise or taking other medications at the same time can have more severe reactions. So how common is it? So the top study based in Italy looked at about 24% of children referred with allergic rhinitis with some degree of pollen food syndrome. The study in Sweden looked at had a greater extent, 25%, so these patients will mostly be birch sensitized. And a study done by my colleague Isabel Schipola, looking at patients who had allergic rhinitis from March to May in the UK, found that 47%, half of those patients, had pollen food syndrome symptoms. All right, so in summary, multimorbidity is common in allergic disease. Epidemiological data concentrate particularly on asthma, allergic rhinitis, and eczema, but multimorbidity, so 2 or more of these, are probably present in at least 10% of young adults, and there are a number of shared genetic risk factors. The majority of asthmatics have nasal disease. Allergic rhinitis is a risk factor for new onset asthma and asthma in the next generation. Treating allergic rhinitis may improve asthma control, but further studies are needed. Atopy is a risk factor for upper respiratory tract infections and lower respiratory tract infections, but I don't think the evidence is particularly clear that allergic rhinitis itself is a risk factor for chronic rhinosinusitis. Allergic rhinitis and atopy are risk factors for otitis media and recurrent otitis media. The evidence that allergic rhinitis is a risk factor for adenoid hypertrophy is a bit less convincing. Nonetheless, treatment with intranasal corticosteroids may be helpful. Allergic rhinitis impairs sleep, but the role in obstructive sleep apnea is unclear, particularly in adults. Pollen food syndrome is common in adults and children. Okay?